I'm Dr. Nguyen Van Min, 42 years old, a general surgeon, and I've been working at Viet Duke University Hospital, the largest hospital and trauma center in Hanoi, for 15 years. Every day we see hundreds of emergency cases, but the one I saw that July night was the most shocking, unbelievable and absurd case of my entire career. Even today, when I tell this story, people laugh, get confused, or if to believe it, but it's real. 100% real. It was documented, published in medical journals with photos, X-rays, everything. A man came into the emergency room complaining of abdominal pain. We examined him, ordered a CT scan, and saw something unusual, something long, moving, alive. It was a snake. A 61-centimeter long live snake inside his cavity. The man confessed he had inserted it through his rectum for sex stimulation. To keep it from escaping, he had also inserted a lemon, but the snake managed to slip past, bit through his intestine, created a hole, and escaped into his abdominal cavity. We performed emergency surgery. It took 3 hours. We removed the snake, repaired the intestine, found the lemon, and somehow the man survived. But part of his colon. This is the story of that night, how one man's bizarre sexual experiment turned into a near-fatal medical emergency, and why some things should never, ever, ever be inserted into the human body. It was July 2024, a hot, humid night, a routine night shift. It was around 1 a.m. The emergency department was calm, just a few minor cases, fractures, small cuts, nothing unusual. I was in the staff room, drinking coffee and chatting with a colleague, when the red emergency phone rang. The nurse answered and said, "Doctor, urgent case abdominal pain, severe condition. Please come immediately." I got up, put on my coat, grabbed my gloves, and ran to the trauma room, Trauma Bay 1. There he was lying on the stretcher, curled up, holding his stomach, sweating, pale as a ghost, groaning in pain. I walked closer and looked at his face, a young man, maybe 35, 40 years old, Vietnamese, local. I asked, "What happened? When did the pain start? Where does it hurt?" He didn't answer. He looked away, eyes shut tight, clearly embarrassed. The nurse whispered, "Doctor, he said something earlier, but it was strange. We didn't understand. You should ask again." I leaned closer, softly said, "Tell me. You can whisper. Don't be ashamed, we're doctors. We've seen and heard everything. Whatever it is, we just need to help you." He hesitated, then whispered, barely audible. "I put something in down there. I can't get it out." I understood immediately, a rectal foreign object. It's not uncommon, though embarrassing. Usually it's bottles, vegetables, sex toys. I asked, "What did you put in? When did this happen? How long ago?" He said, 4 hours ago. Something alive." I froze. "Alive? What do you mean, alive? What kind of thing?" He looked at me, trembling, and said, "A snake." "A small water snake." I was stunned. "Did you say a snake? You inserted a snake through your rectum? Why? Why would you do something like that?" The man looked down, ashamed, and whispered, "For sexual purposes. I wanted to try something new. I read about it online. Some people do it for stimulation. So I tried. I caught a small snake, a freshwater snake, harmless, thin, maybe 60 centimeters, maybe a bit more, and I inserted it. Slowly. But it moved. It started to slither deeper. It tried to escape inside, and now it hurts. It hurts so much." I asked, "Did you insert anything else?" "Only the snake." He hesitated, then said, "Yes, something else. A lemon." "A lemon?" I asked, almost shouting. "Why a lemon?" He said, "To stop the snake. To keep it from going too far inside, like a plug." But it didn't work. The snake was too strong. It pushed the lemon in with it. They both went inside. I couldn't believe what I was hearing. A snake and a lemon, it sounded insane. I thought, what was this man thinking? But I stayed calm and said, "All right, we'll examine you. First a physical exam, then imaging X-ray, CT scan. I started palpating his abdomen, gently pressing on different areas. Right upper quadrant, left side, lower right quadrant. When I touched the lower right, he cried out, face twisting in pain. "Don't press there!" he yelled. I stopped immediately. There was rebound tenderness, a clear sign of peritoneal irritation. Not good. The intestine was likely injured, maybe even perforated. "I need to do a rectal exam," I said. He nodded weakly. He lay on his side in the fetal position, knees pulled up to his chest. I put on gloves, applied lubricant, and carefully inserted my finger. Slowly. Immediately, I felt something hard, round, smooth. The lemon. "This must be the lemon," I said quietly. I tried to move it slightly to see if it could be dislodged, but it didn't budge. It was stuck. Deep. When I withdrew my finger, I saw blood on the glove. Fresh blood. The rectal mucosa was torn, possibly a deeper injury. Things were getting worse. I told the nurse, "We need an urgent abdominal X-ray, both supine and upright positions." We rolled the stretcher down the hall to radiology. The on-call technician was waiting. It was late-night duty, quiet but ready. The patient lay down on the X-ray table, tense, sweating, clutching his stomach. We took 2 films, antero-posterior and lateral. The images appeared on the screen within minutes. The moment I looked, I saw it a strange shadow, long and curved, winding through the intestines. The outline was unmistakable, a snake's body. You could see the head, the tail, even the coils. And below that, a round, opaque shadow, about 5 to 6 centimeters across the lemon, lodged deep in the rectum. The technician beside me leaned forward, squinting. "What is that? Is that a snake?" "Yes," I said quietly. "It's a real snake." But the position was the real problem. The snake wasn't just in the rectum anymore, it had moved up into the sigmoid colon, even into the descending and transverse colon. It had traveled far, dangerously far. The intestinal wall looked thickened. There was free air, visible gas under the diaphragm, a sign of perforation. The snake had torn through the intestinal wall. "We need a CT scan," I said. "Contrast enhanced, abdominal and pelvic. We have to plan for surgery. This could be a full perforation." We moved him to Connecticut, gave him intravenous and oral contrast, thin slice scans, full abdominal coverage. When the images loaded, the situation became terrifyingly clear. The snake was long, coiled through the sigmoid colon. Its head had breached the intestinal wall and entered the peritoneal cavity. A 2-centimeter perforation. Free fluid and air everywhere. The lemon was still there, impacted in the rectum, unmoved. I called the radiologist. He came, stared at the CT, and froze. "What is this?" he said. "Is that really a snake? How did it get in there?" I explained, inserted rectally for sexual stimulation. He used a lemon to stop it. It didn't work. The radiologist couldn't help it. He laughed, shaking his head. "You're joking. This can't be real." "It's real," I said firmly. "He needs emergency surgery. There's a perforation, peritonitis risk, and possible sepsis. We're taking him to the OR right now." I called the team general surgery residents, my assistant surgeon Dr. Pham, anesthesia led by Dr. Tran, and the scrub nurses. We gathered in the small briefing room for a quick pre-op discussion. I explained the situation. Male patient, 42 years old. Rectal foreign body, a snake and a lemon. The snake perforated the sigmoid colon and entered the peritoneal cavity. We'll need an emergency laparotomy. Likely a sigmoid resection. Possibly a temporary colostomy. Sepsis risk is high. Dr. Pham asked, "Is the snake still alive?" "I don't know," I said. "No movement on X-ray or CT. It's probably dead, no oxygen in the bowel, but we'll find out in the OR." Dr. Tran from anesthesia asked, "Is the patient stable?" Vitals. The nurse read them aloud. BP 140/85, pulse 105 tachycardic, Temperature 38.2, mild fever, SPO 296%. Stable, but sepsis likely starting. We shouldn't delay. The patient was prepped and wheeled into operating room 3, our largest trauma suite. He lay on the table as anesthesia began. General anesthesia, endotracheal intubation, mechanical ventilation. I scrubbed in, hands washed, sterile gown on, double gloves, full prep. I stepped up to the table. "Are we ready?" I asked. "We're ready," said Dr. Pham. "Then let's begin," I said. We prepared, the abdomen, sterile drapes placed, the surgical field exposed from above the umbilicus to the pubic bone. I took the scalpel in hand. "Midline incision," I said. From the navel to the pubis, one long cut. I incised through the skin, the subcutaneous fat, the fascia, and finally opened the peritoneum. I entered the abdominal cavity. The first thing that hit me was the smell, foul, rotten, unmistakably infected. Cloudy yellow peritoneal fluid pooled inside, thick with pus. I saw the intestines, the sigmoid colon swollen, red, inflamed, and then I saw it. The snake's head, protruding through the intestinal wall, lying still in the peritoneal cavity. Motionless. Dead. Definitely dead. Dr. Pham, my assistant, looked over my shoulder, stunned. "That's really a snake," he whispered. "A real snake? How did he even do this?" I reached in carefully, grasped the snake by the head, and began to pull slowly, gently, but it wouldn't move. It was stuck. The snake had torn into the bowel wall, embedding itself. The tissues had adhered around it. I mobilized the sigmoid colon, lifting it slightly, clearing the surrounding area. Then I saw the perforation, a hole about 2 centimeters wide, where the snake's head had broken through. The edges were necrotic, black, devitalized. The bite wasn't venomous, but the mechanical trauma had destroyed the tissue. Infection was spreading rapidly. I made my decision. "We'll resect," I said. "Sigmoid resection. No anastomosis, it's too contaminated. We'll do a temporary colostomy, a Hartmann's procedure. But first, the snake had to come out completely." I opened the sigmoid colon along its length, carefully with a scalpel. Inside was the snake's body, long, coiled, brownish green, and the stench was overwhelming. It had been dead for hours, maybe longer, beginning to decay. I grasped it with both hands, pulled slowly, one pull, then another until it slid free. 61 centimeters of freshwater snake. Thin, limp, lifeless. I laid it in the mayo tray. "Keep it sterile," I told the nurse. "We'll photograph it for documentation." The nurses were speechless. One trembled, one laughed nervously, one muttered, "This can't be real. This has to be a nightmare." Dr. Pham shook his head. "Let's keep going," he said. "We still have the lemon." I performed the sigmoid resection, removing the damaged section completely. I brought the proximal end through the left lower quadrant and formed the colostomy. The distal stump was closed, a Hartmann's pouch, left in the pelvis for later reversal in 3 to 6 months. Now for the lemon. "Rectal approach," I said. "I'll push from above, you extract from below." Dr. Pham moved to the foot of the table. We placed the patient in the lithotomy position, legs up, pelvis elevated. From above, I palpated the distal colon. Hard, round the lemon. I pressed downward while Dr. Pham worked from below, first with a finger, then with long forceps. "Got it," he said. He grasped it firmly and pulled slowly, steadily until it came free. A crushed but whole yellow lemon. He held it up triumphantly. "Here it is," he said. "The evidence." I couldn't help it, I laughed. A tired, absurd laugh. It felt unreal, like a grotesque comedy. A snake and a lemon, but it was all true. We irrigated the abdomen thoroughly with warm saline mixed with antibiotics, placed 2 drains, one pelvic, one paracolic, and closed the fascia, then the skin. 3 hours, 3 long, unbelievable hours. The surgery was over. The patient was taken to the intensive care unit post-operative monitoring, full setup. We connected the monitors, the ventilator, and started broad-spectrum antibiotics, piperacillin tazobactam with metronidazole, a triple coverage regimen. 4 fluids were running: crystalloids, lactated ringers for resuscitation. By the next morning, he regained consciousness. We extubated him, removed the ventilator, switched to an oxygen mask. He was breathing on his own again. I sat beside him and explained the surgery. We removed your sigmoid colon. You have a temporary colostomy. In 3 months, we'll close it. You lost part of your bowel, but you're alive. You're lucky. If you'd waited 1 more day, you would have died of sepsis. He cried silent tears. I'm so sorry, he said. It was stupid. So stupid. I don't even know why I did it. I was drunk, lonely. I read something weird online and tried it. I'll never do anything like that again. I nodded. I hope not, I told him. And I hope no one else ever tries something like this. But believe me, we see it often. People insert the strangest things. Bottles, vegetables, toys. Every week someone comes in. But a snake, that's a first. Truly unique. He stayed in the hospital for 10 days. 10 days of antibiotics. Drains removed on day 5. The wound healed well. The stoma functioned normally, stool passing through as expected. He began eating solid food, walking, regaining strength. Then we discharged him home with instructions. Stoma care training, dietary guidance, follow-up appointments scheduled. 3 months later, we performed the reversal surgery, closed the stoma, reconnected the colon, performed the anastomosis successfully. Now he's fully recovered normal bowel function, no stoma, life resumed. But the scars aren't only physical. The psychological trauma remains: the shame, the sexual confusion, the guilt. We referred him to psychiatry for counseling. Therapy, I told him, will heal what surgery cannot. We published the case in Surgery Journal, an international medical publication. A full case report, detailed history, intraoperative photographs, the X-rays, the CT scans, the surgical findings. We even included the photographs of the snake and the lemon. The paper was accepted, published, and within days, it went viral. It spread across the world. News outlets covered it, television stations aired it, social media exploded. Interview requests flooded in newspapers, medical blogs, talk shows. I spoke publicly as Dr. Nguyen Van Min, explaining, "This was the strangest case of my entire career, the snake and the lemon. A sexual experiment that turned into a medical disaster. People were shocked. Some laughed, some were disgusted, but everyone shared it. In every interview, I gave the same warning. Never insert foreign objects into your body. Ever. It's not worth it. These cases are dangerous. The risk of infection, perforation, and death is real." Colleagues asked me later, half in disbelief, "Is this common? Do people really do this often?" And I told them the truth, not the snake. That was the first. But rectal foreign bodies? Very common. Every week, at least one case. Usually sex toys, bottles, vegetables, but sometimes truly absurd things. I've seen a hammer, a broom handle. I've read a report about a bowling pin. Once, a glass candle jar. And every time, it's the same question. Why? And every time, it's the same answer. Curiosity, pleasure, experimentation, alcohol. But sometimes, as this man learned, curiosity comes with a price. I removed a 61-centimeter snake from a man's intestine and a lemon from his rectum, and the man survived. He was lucky because he came to the hospital, he asked for help, didn't hide out of shame, and we were able to save him. Still, he lost a portion of his colon, lived with a stoma for 3 months, and suffered psychological trauma. Now I tell this case everywhere, at conferences, to students, around the world. The message is simple. Never ever insert strange objects into your body. Never insert live animals, never a snake, never a fish, nothing. The body is not a playground. The intestine is not a toy. It can cause catastrophic damage, even death,